are located throughout all of the US, and today we'll have Boston and Phoenix represented. Most chapters have chapter leads that also help to organize events along with input from chapter members. The point is to have an ability to be able to network, share information, seek information, and really develop a good network of Latino health professionals. So we welcome anyone who would like to join. Any questions? We will have a list of all chapters going out to everyone, and feel free to become a member and get to learn all about your colleagues. So today we're going to be having Boston and Phoenix talk. And so we pretty much will have several of these virtual chapter policy forums throughout September and October on all various issues, particularly COVID, which has been really impactful on the Latino community, but also very other relevant, important issues that are important to the Latino community. So we welcome everyone, and I would like to have any feedback and input. We would like to definitely grow and develop resources for everyone that can help us to take care of our communities. So with that, I can lead it off to Dr. Elena Rios, who is the president of the National Hispanic Medical Association. So Elena.
Yeah, thank you, Diana. And Diana, you're doing a great job with coordinating all of the chapters for NHMA. I just wanted to welcome and say just a few major priorities right now. We're involved with the U.S. Department of Health and Human Services committees dealing with COVID-19. And the most important time period right now is, that's happening is involves clinical trials. And we encourage you and your patients and colleagues to enroll. There are 2 clinical trial websites. The one from NIH is the first one, coronaviruspreventionnetwork.org, and that has information on the Moderna trial. The goal is to have 30,000 enrolled, and they're halfway there, but they only have about 18% of Latinos. We are very interested to have more Latinos enrolled so that we can see the impact and the reaction of these viruses. The second website is from Pfizer, one of our partners, and that is the covidvaccinestudy1.com. The second item that is a very big priority for us, of course, is diabetes in all our families, and you're going to hear about that from our experts right now. But there is a brand new program that will start January 1, 2021 for those of you who are Medicare beneficiaries. It's Part D is enrolling people in the enrollment period for an insulin affordability, learn, act, and share, with insulin access for $35 a month. And you can find that information at insulinaffordability.com. And the last thing I wanted to say was that the CME credits for this webinar will be available after it ends. We will be sending you a thank you email with instructions for those who are providers, and it's, I think doctors, nurses, and others can qualify. And the webinar itself will be recorded, and CME will be available for 1 year at our website, nhmamd.org/webinars. So again, I just want to welcome everyone and thank you very much for participating, and let all your colleagues know to join us over the 2 months that we have our chapter forums. And I'm going to kick it over back to Diana and to moderate the session and to welcome our speakers. And thank you very much, both Dr. Enrique Caballero and Dr. Ricardo Correa, for being chairman of your cities. Thank you.
Thank you, Dr. Elena Rios. So I'm Dr. Diana Torres-Burgos, advisor on Hispanic Health with the National Hispanic Health Foundation and chair of the New York City chapter of the NHMA. I would like to go over some housekeeping tips just before we get started. We will be having 2 presentations by our 2 experts, and then we will follow those presentations by a it says 10 to 15 minute, but I believe it's a little bit more like 25-minute discussions, and we really welcome input questions. We would like this to be interactive. The microphones will be muted during the presentations, but please feel free to put in any questions you have into the chat box, and we will certainly try to address as many as we can during the discussion time. As Dr. Rios mentioned, there will be this will be recorded and available on the NHMA website for those who would like to review and see again for more information. Next slide. In addition, you will be getting CME, as Dr. Rios mentioned, and it's very important to know that the objectives of this program is you should describe the key biological, social, and cultural factors that increase the risk for type 2 diabetes among Latinos, Hispanics living in the US. Recognize the need to create comprehensive culturally and linguistically diabetes care programs for Latinos, Hispanics, and determine the importance of developing community engagement projects to decrease diabetes in the Latino population. All the speakers and the moderators have disclosed that they have no conflict of interest to report. And with that, I'd like to move into our first presentation. It's the pleasure to present Dr. Enrique Caballero, who is an endocrinologist and clinical investigator. And he is also the director of the Latino Diabetes Health in the Division of Endocrinology and an associate scientist in the Division of Global Health Equity at Brigham and Women's Hospital in Boston, Massachusetts. Also, he's the chair of the Healthcare Disparities Committee with the American Diabetes Education. And his research interests include type 2 diabetes and cardiovascular disease prevention, as well as diabetes management in racial and ethnic minorities. So with that, I'd like to welcome Dr. Enrique Caballero.
Thank you so much, Diana, for that introduction. And thank you all for joining us this evening. And I want to thank the National Hispanic Medical Association for the opportunity to be with all of you in this program, to put it together and share the virtual stage with my good friend and colleague, Dr. Ricardo Correa, and with Diana. And obviously, I want to thank Elena Rios for her support all along the way. So I want to start talking about how the Hispanic, the Latino community is affected by diabetes. But let me ask you, because I want to start from the very beginning, and I know that I may be preaching to the choir here, since all of you are familiar with many of these things, but I do believe we have the opportunity to for you to answer this question. So here you see, so you need to click and select the correct answer. So which of the following statements is correct? Only one of them is absolutely correct. Is it that race and ethnicity are synonyms? Don't send the message in the chat, just click on the correct answer, please. Latino and Hispanics are interchangeable terms. 1 in every 4 children in the US are Latinos, Hispanics. Latinos have a homogeneous genetic background, or Puerto Ricans represent the most common Hispanic Latino subgroup in the US. Please select your answer, and then our group will be able to put the answers together to display the results. And we'll give you just a few seconds for that. And our team will display the results when ready. Let's see. Okay, wonderful. That is, in fact, the correct answer. So race and ethnicity are not exactly the same. I will go through that very quickly. Clearly, even though we use the terms Latino and Hispanic all the time, they're not exactly the same. By all means, the Latino community has quite a heterogeneous genetic background, so it's not homogeneous. And it is really the Mexican American population that represents the largest group among all the Hispanic subgroups. Next slide, please. Next slide. All right, so very quickly, so race, as you well know, is really based on biological elements. So we are basically divided based on some of these phenotypical features, biological characteristics. And you see there some of the examples, whereas ethnicity is more a social construct. It is not based on any specific race, but it's really more about the sharing of culture, language, traditions, etc. And our community is the best example of that, as we don't not represent, or we don't have a specific race or only one race, but it's really the ethnicity that defines the Latino or Hispanic community. And there is, in fact, a difference because Hispanic refers to people that come from a country that was under the influence of Spain at some point, and therefore in all these countries, Spanish is the language that is spoken. Latino is a broader term that includes people who come from a country that was under the influence, not only of Spain, but other groups like Portugal, and that's the example for Brazil. So all these countries have the same root in terms of the language. It derives from Latin. And as you well know, there's 5 languages, and those are Spanish, Portuguese, French, Italian, and Romanian also. So there's also always a little bit of confusion as to what we use. And by the way, these are terms that we only use in the United States. No one outside the US would really use these terms, but I think it's really interesting in terms of how to define that. Next slide. And as you can see here, there's many countries where we all can come from originally, or our ancestors that settled here in the United States. And I already explained the difference between Latino and Hispanic. We tend to use Latino in some cases because it's more inclusive. And let's also remember there's the new term Latinx that is used more widely now. And that is not only to be more inclusive in terms of origin, but also in terms of sexual preference, orientation, etc., which is obviously something important as well. So next slide. And here, I'm sure that you can recognize some of these very famous Latino Hispanic people, and the reason why I put them all here, which took me a little while to do this, but I wanted to just represent the fact that not everybody, as you can see, has the same features or color of skin. So the Hispanic community is quite heterogeneous from the genetic background. We may all have white genes, black genes, native Indian genes, depending on where we come from. And I think that that's an important consideration, because when we talk about biology, that is something that may be important as well in explaining perhaps some of the differences that we have seen in the prevalence of diabetes. Next slide. Now, the truth is that Latinos, as you can see there, it's about 16% of the total population in the US. The correct answer to my question was 1 in every 4 children are of Hispanic origin at the present time. And you can see there at the bottom of the slide some other interesting pieces of information in regards to the growth rate for this community. And as I mentioned before, the Mexican American being the most prevalent group among all the Hispanic populations. Notice also the $1 trillion in contribution in buying power, and I think that's always something important to consider about this. Next slide. Now, the projection in terms of the population in the next few years, decades, you can see there that it is predicted that based on current growth rates, that by the year 2060, 28% of the population in the country will be of Hispanic Latino origin. And this, of course, may vary depending on how the data are put together every certain number of years by the census, but I think that's in general the most accepted prediction for the next few decades. Next slide. Now that's in terms of the population, but let's get into the diabetes part, because I think this is very important for everybody to acknowledge. And I am sure that if you're a clinician, then you see that all the time. You must have a lot of patients with diabetes that are of Hispanic origin. And there's data that have been shown over the years about the fact that Hispanics, as well as other communities like the Black community, have higher rates of diabetes when compared to the white population. You can see on the left-hand side of the slide, the total diabetes prevalence according to some data in the National Hispanic Medical Survey. And you can see there that it's twice as high compared to the white population, and also in terms of undiagnosed diabetes. And I think that's an important consideration as well, that there are many people out there in our community that have diabetes and they just don't know it. So early detection, screening activities are extremely crucial for our population. And not only diabetes is more common, and by the way, I'm talking mostly about type 2 diabetes, but complications from diabetes, whether that's renal disease, cardiovascular disease, strokes, amputations in general, they are more frequent among Latinos, Hispanics compared to other groups. A problem, there's a lot of cases of diabetes. They are not very well treated sometimes. I have to say that there are reports like the one from the Institute of Medicine that shows that there are inequities, there are disparities in diabetes care as it happens in other areas of medicine as well. So it's important to consider that these things are happening. And what I want to do in the next few slides is to help you get a better sense as to why we think this is happening and perhaps start creating some ideas that could help you as you face this challenge of diabetes in your community. And Dr. Correa will expand by sharing his great experience in this with a program that he's running in Phoenix, Arizona. Right? So this is a list that I put together a couple of years ago because I've been reflecting on what the problems have been with our community and others that are underserved as well in not being able to achieve treatment goals, because that's also something that has been well demonstrated, that it's harder to get patients in the Latino community to treatment goals. And the usual sort of response from clinicians all over the country and other places is, well, it's just that they don't follow the recommendations. And I think there's a lot more than that. I don't think that we can blame the patient all the time. We should reflect on what we need to do better in order to really help them more efficiently. So I created this list that I call the A to Z list for the management of type 2 diabetes in culturally diverse populations. And each of these factors represents an element that is often neglected in clinical practice, but there is substantial support from the scientific piece to say that they contribute to clinical care outcomes. So as you see your patients, I would invite you to reflect on how many of these you're addressing routinely in clinical practice. And if you're not doing some of these, then it would be important to consider how to include them in your visits. Obviously not all of them at once, but to reflect on how you could assess some of these things, because they are important, not only again for this community, but for every patient with diabetes. And by the way, it was mentioned that you all are going to get an email in the next few days with the instructions about your CME credits. So the articles that I will be referring to, including this one, will be attached to that email. So you'll have the full publication if you want to review this in more detail. But let me just give you a few examples about this, because some of them could be relevant. So let's start with biology. Next slide. So the pathophysiology of the disease is very important to be considered. And again, this is mostly type 2 diabetes. There's some data. I won't go into all the details, but suffice it to say at this point that insulin resistance, which is understood as the inability of insulin to promote glucose uptake in peripheral tissues, has been well demonstrated to be more of a serious problem in the Latino community. There is also more adiposity that contributes to more insulin resistance. Abdominal obesity in particular is a problem. And beta cell dysfunction, which is in the end the hallmark for type 2 diabetes, seems to be also a more frequent problem in this population. You can see that there are other abnormalities, and I put a question mark there because we don't know if there is a difference compared to other groups, but there needs to be more research in this area as well. On the left-hand side, you see that there are genetic factors and lifestyle issues that contribute to the pathophysiology of type 2 diabetes. And also at the bottom left, you can see what I always talk about, which is the fact that diabetes is a social disease to a certain degree. There are socioeconomic and cultural factors that influence the development of this condition. And on the right-hand side, you see that once type 2 diabetes occurs, many people, if diabetes is not well controlled, then can lead to more complications and increased mortality rates. Next slide. And very quickly, this is a study that I want to refer to in which we compared what we call at-risk children. You can see that in the middle column. These are overweight children. These are Hispanic children. These are our children that may be above the ideal body weight, but we do not consider that they have a medical problem. And we compare them to healthy controls on the left, and none of these kids had diabetes or pre-diabetes. They were just overweight. And that was defined as being above the 85th percentile for their age and gender. Next slide. And when we compare their metabolic parameters, we can see on panel A that their glucose levels are exactly the same, so no diabetes, no pre-diabetes. But as you can see on panel B, the overweight children have more or have higher insulin concentrations. The pancreas is compensating that obesity and insulin resistance by producing more insulin. That's expected. Next slide. But when you can see a lot of the markers that we measured of endothelial dysfunction and vascular inflammation, turns out that these children have tremendous abnormalities in vascular function. And I won't go into all the details, but each one of those factors that you see on the slide is a marker of vascular dysfunction. So we're not surprised that now we see people that develop heart attacks very early in their lives at the age of 30, 40, something that we didn't see before. And that is because some of these abnormalities are taking place from very early stages in life. Next slide. Next question for you. According to a CDC report that was published quite a few years ago, what is the estimated lifetime risk that was established at that time for developing diabetes among Latino Hispanic children born in the year 2000 or afterwards? Was it 19%, 24, 31, 38, 50%? Please answer now. Okay, let's see if and the answer will be in the following slide. So if we can advance that, please. All right, so let's see. So most of you say 33, 31 or 38%. Okay, next slide. All right, and the answer is 50% actually. You can see the data here. The blue bars represent the Hispanic community. And what was predicted was that for every child from the Hispanic community born in the year 2000 or afterwards, basically they had a 50% chance to develop diabetes. This is really striking, is concerning, something that really calls for prevention strategies from community-based intervention, from education at a very important level through our society about some of these things. And of course, the Hispanic community is not the only one that is affected. Next slide. Now, fears, for example, another important thing here that I quoted here in F. Let me show you one quick example. Next slide. So this is something that we see, you see with your patients as well. People don't want to take insulin. They're afraid of taking insulin. The contagion is that once insulin is introduced to a patient, all bad things are going to happen. People are going to get blind, get complications. And of course, it's not insulin. It's just diabetes that has been uncontrolled for a long time, and insulin is introduced late. So it's important to really discuss that with patients early on in the disease management program. Next slide. Group engagement, next slide. I do believe that in our community, it's really important to try to create some group activities. We like to interact with each other. Next slide, please. And One thing that, for example, I have been experimenting in the last few years is what we call shared medical appointments or group medical visits. Some of you may be conducting some of these activities. These are not classes. These are medical visits that you can do in a group setting. And there's tricks about this. We could discuss that if you want in the panel discussion, but something to try that would facilitate great interaction among the participants and something that could also be beneficial. There's obviously the challenge on how to implement these activities, but I believe that that could be a nice opportunity. Next slide. Another issue is language, for example. Next slide. And believe it or not, this is a true example of something that happened in the Boston community. This was a patient that was identified that didn't speak any English. She was treated for hypertension, and she received a prescription for lisinopril 10 milligrams, and it was signed as 1/D, and the patient was rushed to the ER due to severe hypertension. And all of you can easily identify that the problem was that the patient read once. So she took 11 tablets of the medication, and fortunately she did not die, but this could have happened. That was obviously not the right way to write the prescription. And of course, no one was sure that the patient understood the prescription correctly. Next slide. And another thing that we always wrestle with is whether we translate documents and materials appropriately. The typical example is this about the Friday the 13th, that if you translate that literally, you would come up with Viernes 13, which is actually not what we commonly use in Latin America. It's really Martes 13, so it's a different day, same connotation. So if you only do the translation word by word, you may have it correctly in terms of the language piece, but not from the cultural perspective. So something important to always consider as you work with translating and putting out a lot of materials for our community. Next slide. Nutrition is key. Obviously, I don't have to emphasize that for diabetes management. Next slide. And one of the things that happens frequently is that we just provide recipes or menus to patients, and that may not fit their interest and their schedule. This is a study that we conducted under the support from the Robert Wood Johnson Foundation some years ago. And what we did basically was to educate people by going to the supermarket with them. And our educators really guided people on how to select better foods to take home, considering also their budget. And our promise was that they would not spend more money, but bringing healthier foods. And that's what happened. Next slide. What we were able to do is to reduce, as you can see, comparing the first and the second supermarket visits, the amount of calories and also the nutrients that they were bringing home. So more efficient, healthier foods that people would be able to bring home, which I think is important. When you just provide instructions in the office, that may not be enough for a lot of people. Now, of course, I'm not suggesting for all of you to go to the supermarket with your patients. That would be impossible. But I think we need to think about being creative, perhaps with telemedicine, with virtual conversations that now are becoming more frequent. I think that would be important. Next slide. Next slide. And then to finish here quickly, perception of body image. Next slide. It's important to also consider that the way we perceive body weight may differ from the cultural perspective. Here's an example. We did this as a study in which we asked our Latino patients, all of them women with diabetes, what is the healthiest person that you identify here? And most people identify the ones at the bottom, particularly number 5 or 6, who are people who are overweight. So from that perspective, I think it's an important conversation to have about the fact that a few extra pounds does not mean that you're healthy and that you are well nourished. I mean, those are conversations that are important to have. And again, this is not exclusive to the Latino community. Next slide. Next slide. Socioeconomic status is important, and that, as you well know, diabetes affects not only the higher end, but also the lower end in the socioeconomic status for different reasons. We can discuss that if you want, but I think addressing some of these challenges, and I think that Dr. Rios was also alluding to that in terms of insulin cost and affordability, which is absolutely important for many of these populations. Next slide. Next slide, technology. I believe that telemedicine should be more available for a lot of people, and we have definitely learned during this COVID-19 pandemic that that may be an option for many of our patients. So I did a search only a few days ago, and in PubMed, I typed telemedicine and diabetes. So 2,418 articles came up. Next slide. But then what I did later is to add Latinos or Hispanics, and there were only 51 articles and only 18 randomized clinical trials. So we do need to do more research in our community. So for all of you, if you can think about how to engage some of our patients, and Dr. Rios was talking about that in some of the current studies and other studies like telemedicine and many other areas, I think that's absolutely crucial as well. Next slide. And I think that I'll just emphasize this. You can read the article in more detail so that you can get more familiar with some of these things. And I believe this is the second to last slide, because what I want to reflect with you as a final message here is that we all work in a healthcare system. We interact with our patients. And as you can see in the middle of the slide, we ask them to improve their self-care behaviors. And we're doing that effectively with some people, but definitely not with everybody. So I believe that we need to do two important things. One is on the right-hand side at the top, go away from just the traditional biomedical model and also consider psychological, cultural, socioeconomic factors in order to help people more effectively understand that, have a better conversation, more meaningful interactions with people. And on the left-hand side, I really love this concept of cultural humility. The ability to listen to people, to really be open to their ideas and thoughts and not come with pre-identified concepts that we want to convey and impose to our patients, but really be open for discussions. I think that's going to help not only our community, but every patient with diabetes and other chronic conditions. Next slide. In the summary, you can see it there. I won't go through all the details, but clearly the diabetes issue is a problem in our community. But I do believe that even though we have a lot of serious challenges, there are great opportunities to improve the care that we provide to our population. And I definitely think that culturally, linguistically oriented approaches, understanding all the barriers that our community has to develop effective programs, I think that would be a great way to move forward. And I think that may be a perfect segue for Dr. Correa's presentation of what he has done in his community. Thank you very much for your attention.
Thank you, Dr. Caballero. It was a great presentation and really gave us a real overview of what is happening in the community, Latino community regarding diabetes. So without further ado, I'd like to present Dr. Ricardo Correa. He is an endocrinologist and clinical investigator, a program director of endocrinology, diabetes and metabolism fellowship, also director for diversity of graduate medical education at the University of Arizona College of Medicine in Phoenix. He's also medical director for the local underserved clinic in Phoenix, Arizona, in addition to staff clinician and researcher at the Phoenix VAMC faculty at Mayo School of Medicine, Mayo Clinic in Arizona, and the Creighton School of Medicine on the Phoenix campus. Welcome, Dr. Correa.
Thank you so much, Dr. Torres-Burgos and Dr. Caballero. Basically, after all the amazing introduction of the theoretical part and all of the things that we need to know about diabetes in Latinos, I would like to focus more on a little bit of the practical part, on what we can do. This is an example. There's many things that has been done by multiple groups out there. But this is one of the examples that works on Latino communities. And then at the end, the good thing will be discussion that something that you can use something like this in the future in your community or anything similar that can help. So in the next slide, please. We're going to talk about something called Healthy Lives, that is improving patients that are living with this type 2 diabetes in underserved communities. So as Dr. Caballero mentioned, we know that the social determinants of health are very important in Latino communities. So sometimes telling them about what to eat is difficult because they don't have the resources, they don't have the ability to buy things that we always tell the patients that they can. They don't have also the ability to buy medications that we can that the insured patients can buy. So this is an example of something that you can implement in a free clinic or a clinic that have low resources, and it's basically mainly is being driven by the community, and how at the end this clinic become the center for the community with a program that start for helping the community become the center for the community. So next slide. This is just a picture. All of this start in a clinic in Rhode Island when I was there, and then I tried to expand it to here in Phoenix. Next slide. So a little bit more of the background. As you know, metabolic syndrome and type 2 diabetes are a risk factor for cardiovascular disease. These people have 2 times more risk of having cardiovascular disease if they have their diabetes, has 4 times more risk of having the diabetes if they have the metabolic syndrome. So definitely underserved population and minority communities, including Latino populations, have the higher risk on this. And we can talk about all the social determinants of health, and this is one of the reasons. And we know that in metabolic syndrome, it's not only this glycemia, but also is other components as obesity, hypertension, and others. Next slide. For the Hispanic or Latino population, there is a higher risk of behavioral and metabolic risk factors, as Dr. Caballero mentioned already. There's a higher risk of cardiovascular disease, and Dr. Caballero mentioned the higher risk of diabetes, 50% in the child that are born after the 2000. Lower access to healthcare screen. These are the lower access in the minority, and we are seeing that, for example, right now in the COVID era, where we are seeing that this population, the disparity on the minority has been greater, and this is nothing new. We knew about this. The only thing is that now we are seeing flourish in it. Represent a variety of cultures. We talk about that, and a higher risk of multiple comorbidities, not only one. So as we know, if we map the U.S., the south of the U.S. and the north of Mexico are the highest prevalence of obesity in America. And basically, we can create a new country because of the difference and the polymorphism that occur in this area that we call the border. Next slide. So among Mexican Americans, women have higher risk of having waist circumference, lower HDL, and higher fasting glucose, and also have higher risk of having higher levels of fasting glucose, plasma glucose. And also we can see that the amount of metabolic syndrome have increased through the time in the Latino community. Next slide. So if we talk about behavioral risk factors compared with non-white Hispanic, smoking and alcohol consumption is lower in Hispanic population. I was very surprised when I read about this because, you know, thinking about in the border and close to Mexico and tequila and all of that, but we are less as Hispanic, less consumption that, but we are more living more sedentary life, and physical inactivity is higher in us. And our dietary habits, as Dr. Caballero mentioned, it's worse than the non-white Hispanic. So this means that our diet is based more on carbohydrates, sugary drinks, comparing with the non-white Hispanic. Next slide. So there is a higher prevalence of diabetes. So there has been a lot of intervention done in the non-Spanish population about diabetes intervention to prevent progression of diabetes to help those populations, and many of them have been very successful. There's a lot of great evidence, but there is not so much strong evidence on community-based intervention in Hispanic population when you translate that to their culture and to their language. So this project was originated for that, to decrease morbid mortality, to increase health literacy, and to decrease the cost of care and the cost of complications. Next slide. So basically, the intervention is the connection of that healthcare center that is not abundant of resources, but have a lot of volunteers and people that want to help through multiple layers that I will try to explain, that include communication by peers, communication by the physicians and the providers, and then having these socioeconomical barriers decrease, and having more a community, the healthcare center become a community center for them. Next slide. So this is the clinic. So as I mentioned, so Vida Sana program is a translation coming from a material developed in English from Dr. Susan Oliveiro. And this program was based basically on at the level of a 5th grade student. So it was basically on thumbs up and thumbs down, and trying to recognize what was good and what was bad, and then correct it if they were at the beginning it was bad. So if it was not correct. So it was modified for the culture. At the beginning, the culture that they were using was the culture of the Latino community in Rhode Island. That is mainly coming from the islands like Puerto Rico and Dominican Republic and Azore Islands. There was some community there, and then when I moved to Phoenix, was adapted to the Mexican community that was living in Phoenix. So in both places we found the same similar things, even though they were different geographically, the Latino community. Next slide. So this is just an example of how the book is. It's just a thumbs up and a thumbs down. How do you consider that this is good or bad? The same thing at the beginning, the patients recognize the overweight population to be good. And then with times after the 8-week periods, they will recognize that this is a bad thing. So it's to increase the health literacy about the metabolic syndrome and diabetes. So it's an entire 8 weeks program. So the patient comes to the clinic and then they get enrolled in the program if they want to participate. The patients are followed by a healthcare worker that in Spanish we call the navegantes. And then the patients, depending on, this was in the clinic in Rhode Island, we have some grant money. In Phoenix, we don't have the grant money. So in Rhode Island, there was some incentive that you get $10 at the beginning, $10 in the middle, and $10 at the end. And also in Rhode Island, we have the ability that some of the community people were also helping with childcare. So when they were in classes, then there was childcare help. Has been a little bit more difficult in the clinic in Phoenix, but that's our goal also, because these are people also that have other commitments, and it's better to integrate everything, every part of the family, including the kids, so they can come and participate. Next slide. So it's a 2-hour session group, and basically, I will talk a little bit more of the navegantes, but they meet with the navegantes in these 8 weeks. So basically, there is no healthcare provider in the sense of a physician or a provider involved during these 8 weeks. It's basically driven by a peer that is called the navegante, that is going to teach and do multiple other things during these 8 weeks. So they are in small groups, usually between 10 and 12 participants. The classes, the majority of them are given in Spanish. There was one group that they were the younger generation that was in English, but the rest of the groups were in Spanish. And then they decide how they want to meet, how frequent they want to meet, and what they want to do. And then with that constant communication among that, then start something naturally developing. So, for example, one of the member of the community, she's not a chef, but she wanted to cook, and then Fridays was a cooking day. So all of the members of the program came and then bring something, and they cook salad and then distribute among the members. There was the priest that was very important for the Hispanic community, and because it was part of the community, there was a spiritual guidance once per week. So that is what I mentioned, that this healthcare center that was just a healthcare center where you wanted to receive some attention because you have some kind of disease, at the end became like the center for the community. People were looking other things, not just for help because you have an acute event or chronic disease. So this is some of the collaborators. Everybody is a volunteer. Nobody received any money for doing this. Next slide. So the Navegantes program is a little bit different. So you prepare them before they start with the program. So this is a 10-week program where this is the ones that are trained by the providers. In our case, by the physicians and nurses that have experience on training this. So basically, you train them in multiple things, in medical interpretation, in life coaching, in diabetes prevention programs. And at the end, they receive their certificate, and they are very proud of showing their certificate of being a healthcare worker or a navegante. So they gain, besides helping others, they gain their own certificates. Next slide. You can see like some pictures of their certificates. So they are not just a peer support person, but also they get trained, and then even they can do medical translation. They are approved by that. Next slide. So what they do is in the first visit is that the navegantes that administer a healthcare literacy survey to the patients, basically to assess the knowledge. They do certain other things that we train them to do, like the weight, the BMI. We measure the cholesterol and the blood pressure and the fasting glucose. And in the next meetings is basically all the things that are in the curriculum that the navegantes are going to teach, and the final is the assessment of all the initial, again another survey, and again another of the blood analysis, and then the impact factor of all of this. So just to show you a quick example, and this was published by the Rhode Island Clinic. So 138 patients participated in the Vida Sana program. 47% of them completed the course, so a very high percentage. Thinking about that, these people work the entire day to get a little bit of money to survive. So this was a high percentage of completion. Next slide. Among the 138 who began the course, 78 completed at least 6 to 8 sessions. So meaning from the 8 weeks, almost the majority of them completed the 6 to 8 weeks. Among those who take the pre-test, pre and post-test, 69% score higher. So their knowledge about their disease, in this case about diabetes, increased. So the health literacy increased. Among the ones that completed the course, there was a weight reduction. This was a short term, so we're not talking about a long-term course, but a short term of 1.85 pounds, an average change on BMI of 0.34, and a change of waist circumference of 0.83 inches. So all the parameters in the metabolic syndromes improve. The same thing happened with the A1C, a reduction of almost 0.1% on the A1C. Of course, we're not talking about a long-term program. This was a short-term program. They maintained the blood glucose with on average after this, and then the systolic and diastolic blood pressure also improved. So the good thing about all of these improvements that we have been following these patients is that they keep them even though they are not part of the program anymore. And the other thing is that many of them became navegantes for the next sessions. So they continue to be part of the program in a different way. They feel so involved, and they saw reassurance that they even continue in the period of times that the program was not running to participate in the program. Next slide. So Vida Sana is just one of the initiatives that exist out there for community centers that do not have the resources to create a stronger or very expensive interventions for underserved population, including Latino population, and this is one in Spanish. So at 8 weeks, as I show you, this is a short program, but at 8 weeks, we have shown the most important thing was healthcare literacy improve. The limitation is that we don't have a comparison group. Something that we're doing right now with the COVID era is about using telehealth to see this work. Has been a little bit more difficult. It's just because the technology is not available for everybody, and some of them are using their phones, and it's the phone data and all of that is not everybody's available. So has been a little bit struggling during the last 6 months to work with this population. And the plan is really to expand this to many of the inner cities community healthcare centers that do not have resources, that have a lot of underrepresented minorities, in this case focusing on Latinos, so they can apply this program, and then they can see effects on decreasing the metabolic syndrome and the diabetes control. Next slide. So this is all the people that have collaborated in the different clinics. And next slide. So something that I want to say is about that this was created by a group of people that really cares about the Latino community. And this is what I wanted to bring is like, there are things that are out there. You don't have to create a wheel. This is one of the things that you can collaborate with an organization near you, or with, for example, an NHMA chapter, and create something like this. And you can join with a group of, for example, students that are very interested. That's something that I'm doing here in Phoenix, trying to bring the LMSA students that they are very interested. They're analyzing the data. They participate with it as navegantes. They participate with the community. They are very integrated. There is opportunity for developing, and that's one of like the big project that we have in our chapter is this work with this underserved clinic that slowly we want to grow and then provide more care for more people in that community that need it a lot. Next slide. And thank you so much.
Thank you, Dr. Correa. That was a wonderful presentation. And I want to thank both our speakers, Dr. Caballero and Dr. Correa, for their really insightful presentations, not only what the problem is, but some strategies to actually help deal with diabetes in the Latino community. So we have now come to the session where we'd like to open it up and answer some questions. I already see we have a couple of questions on the chat, and I'll start with the first one. where, and this is to both speakers, where does prediabetes enter the picture, and how can we push for more environmental policies like taxes on sugar beverages, which has had great outcomes in Mexico City? And do you refer patients to diabetes prevention program after a patient has been identified with prediabetes?
I can probably start then, Ricardo, you can obviously add to that. There is, and some people may be familiar with that, an important study that was conducted here in the US. It's called the Diabetes Prevention Program. I've been very fortunate to be a co-investigator in the DPP since we started it back in 1996, actually. So there's a lot of history, and we have been able to follow people for over 2 decades. And the bottom line is that it is clear that type 2 diabetes can be prevented or at least delayed in most people. And there was a good representation of Hispanics in that study, most of them from the Mexican American community. But it is clear that these interventions work. Now, what is exactly what we found? That weight loss, at least a 7% weight loss in people with impaired glucose tolerance. So these are people that have elevated blood sugars after an oral glucose tolerance test, and it's one of the categories for prediabetes. They were able to reduce the risk of developing type 2 diabetes by 58%. So weight loss is the most important intervention to prevent type 2 diabetes. And the way we accomplished that was by guiding people on a better meal plan, a balanced structured meal plan that was also culturally appropriate for each of the groups that participated, and physical activity. Our goal was 150 minutes of exercise per week. So that translates into at least 30 minutes of exercise 5 days of the week. And that was very powerful. That's the most important intervention. We also used metformin. That was the only medication that we used, and it's been validated. It's a way to also reduce the risk for type 2 diabetes with a 31% reduction. So the winner was lifestyle modification. So having said all that, there are throughout the country different opportunities for people to participate in diabetes prevention programs because this has been replicated. What we did was from the research perspective. Now there are programs that people can join. So Ricardo, you may have some other ideas about how people could access some of these at the community level, or Diana, you may have more information. But what I know is that if people go to the diabetes prevention program site, the National Diabetes the NDP as well, the National Diabetes Program, that's the CDC's way to translate all this information into clinical activities. It is likely that people will find a diabetes prevention program in their own community, in their own city. So I think that would be the easiest way to refer people to start a diabetes prevention program. And if not, I think there's always the possibility to start a diabetes prevention program. I think that would be great. But then the other part is not just the clinical activities and all this, but it's at a higher level. How could we combat diabetes? Because this is, as we said before, a societal level with the inappropriate access to healthy foods and not enough places to exercise, all these different factors. And I agree. I think that we need to make changes at a policy level that would help people have access to healthier foods, to exercise more regularly, something that we should really work on. So I think this is something that needs to be done in parallel. So I would say identify local diabetes prevention programs, but also help your own community. And I guess we all collectively try to influence, this is what we're trying to do also in this organization, influence policies. And this is what Elena has been fighting for years as well, in terms of influencing some of these changes that could benefit our community. But I don't know, Ricardo or Diana, you may also be able to add a few things.
Yes, so I just want to add two things that something that you mentioned, Caballero, is one is that, for example, something that I have noticed is that there is the CDC and the National Diabetes Program. There is a lot of resources, and even per state, there is economical resources to develop these diabetes prevention programs in the underserved communities. Mm-hmm. Depending on the state where you live, depending on the political party that dominates the state, then you have some resources or not. When I was in Rhode Island, there was a big incentive were thousands of hundreds of thousands of dollars to the clinic if we were enrolling people for the DPP, and of course the clinic benefit from that, and it was an incentive. So the program was, and a different program was developed, and then the clinic will benefit from that. Definitely now Arizona is not a state where we receive money from the state, so this is very difficult to find at that level. So something that is connected with the next thing you mentioned is the policies that needs to be changed. And this cannot be like, if I live in one state, I have benefits, and if I live in another, I don't. And then here we are in the border, seeing like in Arizona, 43% of the population are Hispanic or Latinx community. But the resources comparing here with what I compare with Rhode Island is less. So this is something that fighting against the system, but with resources, with trying to change policies at the state level, that helps a lot. Usually you will find organization like NHMA. Here we have something called Chicanos por la Causa that will help to create those policies and go through the local Congress and senators to make some changes. But it takes time and it takes effort, and that's something that that's what I put in a slide, empower yourself, because that's another way that we can empower ourselves and help our community doing that.
And you know, Diana, because just to expand on what I think someone was asking specifically about, is it a good idea to increase taxes on unhealthy food so that we sort of dissuade people from getting all these things that we don't want and buy healthier foods? Well, I'm not sure that has worked perfectly well in the different countries that have tried that. In fact, here you probably have that experience, Diana, that in New York, I do remember that there was that sort of plan of banning the sort of large sodas at some point a few years ago, and that didn't pass because people said, who are you, government, to tell me what I want to drink? I want to have the freedom of doing whatever I want. So I think that clearly speaks to the fact that the population needs more education, needs to be more aware about sort of choices. But ultimately, I think that the alternative is probably to reduce the cost of healthy foods and make them more available and more affordable, so that hopefully that could also help in that decision-making process. But obviously a very difficult thing to do. But the reality is that for a lot of people, choosing healthy foods is becoming more of a problem also from the socioeconomic perspective. So that definitely needs to be addressed somehow.
And I just can speak from one experience where we were able, through advocacy and really going to the legislation in New York City Council, to be able to remove soda from child Happy Meals, that they could only provide water and juice. So I think advocacy and policy changes are still a really good way to be able to make something seamless, which doesn't require increased cost for the consumers. And so it took a while to do because, obviously changing policies is not something that happens overnight, but it's certainly a strategy that we can use to do that.
And I see, Diana, that I think someone wrote here, I think it's Rose Cano said in Seattle, I think that's a great idea, that the tax that is established on unhealthy foods and sodas, that money goes to support food vouchers for Safeway and farmer markets. I mean, those are sort of great ideas that could be perhaps built upon to really do this at a better level.
There have been many questions, so I just want to move along a little bit. I think I do want to make a comment from Dr. Lorena Bonilla, something that is really not clear, and I really think you did a great job, Dr. Caballero, is, to realize that race is a social construct, and that sometimes is very hard for people to understand. So it's something that I think we still continue to need to have to educate. So I just want to make that point, that I swear that up there. There have been several questions on diabetes prevention programs, and I'm just going to go through a few, and I'm sure you've seen them. And that is, one, the CDC calls completers in DPP those who complete a session 6 months. So they say that Vida Sana participation matches that. Also, and where was the other one?
Can I just clarify one thing, Diana? Because what I said in my presentation was that race is actually a biological sort of element, whereas ethnicity is social.
That's what I meant.
think that,
I'm sorry.
but what Lorena is referring to, I think, and she's right, is that ultimately race, it has to do a lot with social determinants. And I think that's true, although from just the original perspective of how we divide ourselves into different races is really based on biological features. But of course, there's the whole influence of social aspects that determine, of course, what happens with each of the different groups that are divided by race and ethnicity. So I think that goes along with that.
Totally agree. Totally agree. Other comments is that even in pretty resourced areas, DPPs are in Spanish are really hard to find. How do you go about, reproducing, having these programs available in the communities?
The whole challenge is about how to establish programs. And I would actually sort of make this bigger, because it's not just diabetes prevention. I think it's a diabetes management programs. I think because what Ricardo presented, that's a very nice example. It's a diabetes management program with clear impact in how to improve self-care behaviors, etc. And unfortunately, there are not many of these effective programs, whether we're talking about diabetes prevention or diabetes management throughout the country. And if you find them, these are unfortunately isolated efforts, like what Ricardo has done, what I actually did when I was at the Joslin Diabetes Center before, and things like this. And many others have, of course, implemented programs. I think that what we need is probably find ways to share some of these experiences to create a bigger network. And this is what we have been discussing, in fact, through our meetings in the National Hispanic Medical Association, that, as people join and collaborate, we can get to know each other more. We can have better ideas about how to put some of these programs together, about how to collaborate, how to share our sort of success stories, and obviously also our failure stories, so that people don't have to go through that painful path again. But all these different things that could be very beneficial. So I think that we need more of these programs, but it all starts by having people that are interested connecting with each other. And I think that would be another very interesting thing that the organization can really do.
Well, one person asked, the CDC has shown that it's very difficult among Blacks and Latinx to, achieve the 5%. So do you think that there's good outcomes with lower weight loss? You mentioned weight loss is a very important thing. How much weight loss?
Well, for prevention, so what we found was that a 7 to 10% weight loss was enough to decrease the risk for type 2 diabetes. Now, this is again in people with impaired glucose tolerance, just to be absolutely sure that people understand that. There's two ways to define prediabetes. One is if the fasting plasma glucose level is elevated, that's between 100 and 125 milligrams per deciliter, or if people have impaired glucose tolerance, and that's with a 2-hour glucose tolerance test, and if the level is between 140 and 199. We only included people in the DPP with impaired glucose tolerance, prediabetes. Now, in that group, 7 to 10% weight loss was enough to reduce the risk of type 2 diabetes by 58%. Now, the more weight people lose, obviously the more significant the diminution in the risk. So I think that's important to consider. Now, how to get there, I think that's the challenge, and how to replicate that, because again, these needs to be based on culturally appropriate interventions, guiding the community. I think that what Ricardo has done about involving people from the own community and navegantes and peer support, I think that's fantastic. That's what we need to do in order to motivate people to make some of these changes. So there are not many programs, but I think that it's important to identify those that exist. And if not, this could be really an opportunity to create something new in many of our communities.
A lot of people are asking how they can duplicate Vida Sana. And also, would you consider doing telehealth with families, not just the individuals, since, it really is a family issue to better, improve the diet and nutrition. So what do you think?
Something to add before answering the question, it's something to add to Dr. Caballero is that this is for prevention of diabetes, but patients with diabetes, they have been shown that if you reduce more than 5%, the complication of diabetes, including cardiovascular outcome, reduce. So not for the prevention, but for the ones that have diabetes, 5% is a good. And then there, if you maintain that, there is a biological clock that continues that, and your cardiovascular outcomes decrease. So yes, there definitely ways to replicate Vida Sana. The only thing is just the willing to do it. It's a program that is open, and then it's just a program that we can share with everybody. The authorship is still in the Clinica of Esperanza in Rhode Island, but they were more than willing to share with everybody. And then you just have to coordinate. They will train you, and then you have to coordinate with your own community. And then, of course, you need a group of people, because alone it will be difficult. So you need a group of people that help you. But definitely, it's a program that is open for everybody. And everything comes, like, it's in Spanish. Everything comes in package. You don't have to just make copies. They explain your detail, how you train navigantes, how the navigantes train the thing. So everything is already done. So,
and you know, Ricardo and Diana, maybe you agree with this, but I think that one of the mistakes that has happened historically throughout the years is that if people recognize that something needs to be done with the Hispanic community, their initial thought is, well, let's just have materials in Spanish. And by doing that, that's it. We have a program that is appropriate for the community, and that clearly is not enough. And as I said before, it's not about language, it's really about culture. And I think that Ricardo's examples about how to address health literacy and make things really understandable and easy for people, guiding them, taking their hands, and all these things to really get them to where you want them to be is what we need. I mean, not, of course, to undermine the efforts of people that are trying to do something, but just to be aware that translating materials is not enough. Obviously, I think you need to really consult with people that know exactly how to engage in this. And you may be obviously the ones that are listening today, the people that can guide others on how to do some of these programs.
One other question from one of our participants is, what has been your experience using metformin in the pre-diabetes stage?
Oh yeah, sure. So what we did is that we had then in the DPP 3 groups. So one was intensive lifestyle modification that I just explained. We had a placebo group and then metformin. Metformin group took 850 milligrams twice a day. And that group was able to reduce the risk to type 2 diabetes by 31%. So 58 with lifestyle modification, 31% with metformin. So not really inconsequential. And but lifestyle modification was better. At this point, the recommendation is to use metformin if lifestyle modification is not leading to the weight loss that we said. It is perfectly valid, and metformin is actually recommended in many of the guidelines for diabetes prevention. We actually have done some guidelines for Latin America that I participated in when we officially recommend metformin if lifestyle modification is not effective. And that can be done. And metformin is inexpensive, we have 50 years of experience with the medication, so that can be done. Just to be careful about selecting the people. In our study, the people that responded best to metformin were people with a BMI above 30 or 35. So people that have, for example, a BMI of 26, 27, probably are not the best candidates, but the higher the weight, the more likely to respond to metformin. Second is those people that were younger than 60 years of age. If people are above the age of 60, for diabetes prevention, they did not respond to metformin. Not for diabetes management, that's a different story, but for prevention. And the third group that got a great benefit was all those women with history of gestational diabetes. In our community, that's a very common. So women who had a baby, had gestational diabetes, now their blood sugars are fine. They have a huge risk of developing type 2 diabetes. So in those cases, we found that lifestyle modification and metformin could be a good strategy. But people can look at the reports and the publications that we've made to get more specific recommendations.
We just have a couple of minutes, so I'll try to see if we can do two quick questions. One is, and this is my own question, during COVID, it's been obvious that diabetics have been at very high risk and had a high mortality rate. And so now they're in the process of, doing clinical trials, but they also are having difficulty not being able to get underrepresented minorities into these trials. So, what are your thoughts about getting participation for these communities who are being impacted, but yet are not really participating in the trials?
So yes, so definitely this is a very important question, is because we have been seeing different things that is happening with COVID and diabetes. One of the things is a syndrome of insulin resistant. Patients that comes with diabetes and there's an inflammation process, and the amount of insulin that they require during the acute phase of the COVID, it's 10 times the amount that they require before and then after the inflammation process. So that's one of the things. And the other thing is that people develop new onset of diabetes. And this is an international registry that is happening right now. It's called COVID Diabetes Registry. The big problem is that these are big centers that are recruiting, like at the VA in Phoenix, we are one of the center recruiting. But regarding your question on how can we enroll underrepresented minorities that are small community centers, to this it varies depending on how your community center is dealing with the COVID. For example, one of the limitations that we have in our community center is that we were not able to do testing because we didn't have the money for the testing at the beginning, and we were not able to follow the patients with COVID. So if any patient came with us and we knew that they have diabetes and they presented with COVID, we'd have to send the patient to one of the big hospitals. So we will not be a center for recruiting patients for this kind of studies, because we will not follow. Depending if they were a bigger community center that have more resources and they were following the patients, that's something that we are doing a outreach to them and telling them about this type of study that is happening. Some of them are a little bit reluctant, most in these kind of places, due to certain other things, immigration, and they're undocumented and things like that. But definitely the outreach is going, and say we need Latino population to be involved on these studies to see what is happening, because probably it's different from the rest. I don't know if this makes sense.
No, thank you very much. I mean, we're running a little over time, so there's still some questions that we may be able to address a little later through email. And I want to thank our both speakers. What I'd like to do as before we leave is just quickly from each speaker, well, obviously from each speaker is just the one thought you thought, one thing that you think is most important in helping our Latino communities regarding diabetes. And as you can all see, these are the upcoming virtual forums that are coming in. And as you know, we'd like to respect people's time, so we'll leave it with the two comments from our two speakers. And I want to thank everybody who has been involved. And we will certainly get out all the information to all the participants. And the emails have been provided, so if you have any questions that you would like to make after this, please feel free to contact our great speakers. So again, last words from Dr. Correa and Dr. Caballero.
Yeah, I can go first. So first of all, thank you all for joining. I hope that this was helpful. I would invite everybody just to try to think about how you could in your own community impact diabetes more effectively. And again, it's not just diabetes, there's many comorbidities that are related to diabetes. And think about how in your center, in your clinic, in your hospital, people are really embracing or not diversity, inclusion, and all that. Because to me, and what Ricardo was also talking about, why people don't participate in clinical trials is because they don't find that the place they go to is really welcoming them. It's not just about putting science in Spanish. Again, it's about really having a culture to embrace and respect different groups. So I think there's a need for people who could become really champions in developing many of these different programs. And I think that you all are doing it for sure in your communities, but maybe there's a way to invite other people to join this sort of fight against diabetes in the Latino community. I think that in clinical research, for example, having bilingual, bicultural research assistants and people that work in the studies that truly understand the culture are important, and people that work with clinicians and researchers to create a community that can expand the reach. I think that's what we need in order to really win the battle against diabetes. So thank you very much and good luck with all your activities.
No, thank you for participating. I think that Dr. Caballero summarized everything that I wanted to say. I think that one of the things that the last phrase is empower yourself. Many of you are making difference in your community. We need more people. Convince others to help you. Convince your friends that are that have some kind of interest in this. Partner with the students. The students are anxious of doing help. Partner with students. Partner with the trainees. Partner with other colleagues, and then you will make a change. And that's what we need. Probably sometimes we think big. We think we need to make a change nationwide. No, we can make a change in our local community, and that's as important as making a change nationwide.
Thank you so much, and from Dr. Correa and Dr. Caballero. And I want to thank you all for joining us, and I wish you all a very good night. All this information will be coming to you soon. And please go on the website, www.nhmamd.org, and we will have all the information, but you will be getting emails from the office with all the information, contact email, slides, and links and articles also for those who want to have more details. Again, thank you everyone and have a very good night. Buenas noches.
Buenas noches.